Hello, everyone, and welcome to a sold-out fact versus fiction. First time. Thank you all for coming here. Thank you for supporting us. So I think I know about a third of the room, and it's wonderful to see all my friends. But for all of you that I have not had the pleasure to meet, I'm Eva Dubin. I'm the founder of the Dubin Breast Center. Thank you, thank you. 22 years ago, I was diagnosed with breast cancer. And I realized then that there was definitely a need at Mount Sinai, and I felt actually in New York City, for a comprehensive center where we could take care of everyone and include the integrative services, and that we could take care of every woman regardless of ability to pay. Fast forward 14 years ago, we opened the Dubin Breast Center, not knowing we were partners in crime already then. We did not know if we would have any patients. And today, we have grown and grown, and today we see between 180 and 200 patients a day. So, we could probably see more, but we need more space, and I'm working on it daily. So we have an exceptional team at our center. Today's panel represents some of the esteemed experts that we have. The panelists will try to figure out what is fact and what is fiction. And I really hope that you have a lot of questions for them. So enough about me. I am privileged now to introduce the speaker of today, which is our amazing, acclaimed fitness instructor, author, and speaker, Stacey Griffith. Stacey is also a Dubin Breast Center patient, and we are so lucky to have her here today to tell us about her story. So please help me welcome Stacey.
So I'm not really used to playing this role in this moment in my life. I'm used to being the coach, the teacher, the person who inspired you to get through your journey with breast cancer, not my own. So I'm going to ask for a little bit of help to get through this 3-minute. Thank you for limiting it to 3, because I don't think I can talk for much longer. When I need your help, I'm going to point out to the audience out there, and you're going to either clap, woo, scream, drop your bag, take your jacket off, whatever it is that I need to get through it without crying. So, are you with me? Whew, all right. So, pre-COVID, I was not a big advocate of getting mammograms. However, I did get them. And then COVID hit, and none of us actually that year were able to get a mammogram. And then I just kind of went with the one I got in 2019, as that would be it. Flash to 2020, and we do routine checks on each other, Michelle and I. Highly recommend that, ladies. And she felt a little something, and I have dense tissue anyway, so I just thought I worked out a little bit too hard that day, so I didn't make anything of it. Another year went by, another exam went on, and she felt it a little bit different. And I still didn't worry about it. And so my friends kind of pushed me, as they do, to go get a mammogram and go see somebody about it. Cut to, I also was a middle-aged woman in menopause, so I was miserable in my hot flashing every single hour of the day. So I went to the gynecologist for that also. Are you with me? That being said, I was put into this extreme 24-hour blur of a moment where I was in a mammogram / one-stop shop ultrasound biopsy doctor who basically told me, you 99% for sure have breast cancer. And I just got completely numb, and it's all a blur after that phone call that I made to Melissa Spoler. I can't thank you enough for catching that phone call while you were at dinner. I'm sorry to interrupt you that night. And Melissa and all of my friends held my hand as we walked to the Dubin Center. And that was after Eva called me that night to say, please don't be scared. We got you. Come see our team. Are you with me? Because this is where it gets extremely, extremely real. And I know that 1 in 8 of us are potentially going to get this disease. And I hate that for us, but it's real, especially when it happens to you, which I hope it doesn't. From that moment on, when we all sat there, I think I probably asked every single person in my close-knit of friends to be there. There might have been 20 people inside of Dr. Tierston's office. Sorry about that. Everybody at the Dubin Center was like, wow, you don't roll alone, do you? I have never been more supported. I have never been told not to be scared. I have never felt more a part of a team in my entire life, aside from when I played basketball as a kid, than I was at the Dubin Center. Between the extreme testing, genetic testing, options, I qualified to get into a trial, the Compass trial, I believe, which for most people, being in a trial, you may not want to be in a trial. Me, I love risks. I love jumping out of planes, which I have never done, but I don't have one bit of fear about a trial when it came to what these women and men, I didn't really have any male doctors in there, but I do love them. Evan was a nurse assistant, but he's amazing too. I have never felt more confident in beating breast cancer with this team of people. Are you with me? Okay, to wrap it up, this is where Dr. Port comes into the team, which honestly, I went from, okay, I'm gonna have a double mastectomy with a giant tattoo of a dragonfly. No. I'm gonna have one removed. No. What am I gonna do? I literally did not sleep. And if it wasn't for Dr. Port explaining to me that after month 4 of being in this trial, before I had the surgery, after chemotherapy, before radiation, I was cancer-free. So the one time I decide to go to my doctor visit alone, the one time I go, I roll into Dr. T's office. There are like 7 masked people in the room. I was like, what is going on? What is happening? Why are all these people in here? I gotta call my mom. I get my mom on FaceTime. And they're telling me about how amazing my response is to this trial, and that it doesn't happen all the time that people have this amazing response physically to what was going on in my body between the chemotherapy treatments, the immunotherapy, all of it. But I have to say that it takes a village to get yourself to feel this way. It takes a mental attitude of confidence and faith, whatever that faith is for you. I spent every single morning going in the ocean taking cold, freezing cold showers on my hair so that it didn't fall out, which some of it did, some of it didn't. I did my own version of cold capping, which was meditation of freezing cold water and going, "You're not going anywhere, you're not going anywhere, you're not going anywhere." And just really, really, really amazing teamwork is what it took to beat cancer. So that's my story. And then I'm going to just do this because it's what I love to do. Fundraising is my sport. This is not on the agenda, sorry ladies, but everybody has one of these cards on their table. Please, 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 I'm asking you, because this is my life now forever. The Dubin Center needs a lot of things. We need more rooms. We need more staff. We need more volunteers. We need more locations. We need a better, bigger surgical area for Dr. Port. We need more things. People need you. Somebody in your life that's not as privileged as a lot of us are in here to go through what we did with all of these amazing things. The reason the Dubin Breast Center is so amazing is that it caters to every walk of life. I made so many friends in the lobby there. Some of them lived on 135th Street and Madison. Some of them lived on Park Avenue. I met a 27-year-old lawyer who was about to get married who was stage 4. 27. We need you guys, okay? So that's it. Thank you so much for coming.
Thank you so much for sharing with us, Stacy. What can I say? It's been such a privilege to get to know you and your incredible circle of friends and family and to care for you. Women such as yourself drive our work every single day at the Dubin Breast Center, and your accomplishments inspire our own efforts to change the standard of care for our patients through the discoveries, both big and small, some of the things and the needs that you mentioned. Our reward is seeing survivors such as yourself thrive and continue to make an impact. And your success really encourages us to drive forward, to push the boundaries of what is even possible. It changes every single year. We have progress to report. And we also want to become increasingly innovative in our approach so that we can change the landscape of breast health. I can't thank you enough for being here today, sharing your story, and truly entrusting us with your care. You are so special. And I'm so grateful to all of you for being here and happy to see, as Eva said, so many new faces. I'm Dr. Lisa Port, the director of the Dubin Breast Center. And first, I want to thank my partner, Eva Dubin, who you already met, which our work together has been one of the most meaningful things to me in my life. It's because of her passion and her philanthropy and her leadership that the Dubin Breast Center has become synonymous in New York for the most advanced and compassionate breast cancer care. We treat people, not patients, and we welcome everyone regardless of ability to pay, as you heard from Eva and as you heard from Stacy. This has been our, thank you. This has really been our shared mission from the beginning, and I never miss an opportunity to say it's been such a huge honor to be on this journey with you. This is Fact versus Fiction. This is a tremendous forum for our experts to share information with our community while thanking you also for supporting us at the Dubin Breast Center. Your generosity and shared sense of mission make our work possible so that we can deliver this most advanced care to everyone who comes through our doors. We have, again, reached capacity in an even larger venue than before, and there was a waiting list, no less. So we're so appreciative, and it only emphasizes to us how incredible the need is that we are filling by sharing with you what we know. A breast cancer diagnosis touches all aspects of life, as many know, and it also touches a lot of aspects of health, and it comes with an endless stream of questions, and it brings up other questions related to overall health, such as those surrounding hormones, diet and exercise, screening for other cancers, and so much more. By educating people, we empower them, we hope, to ask the right questions and work with them to find the best solutions for their own health. From my standpoint, this event today has two themes. The first is a constant with this forum. It's separating fact from fiction. And there's really more dissemination of misinformation and what I call partial truths. There are so many partial truths out there than ever before. And what is crazy to me is that it's so ironic that it's actually often the misinformation that is a source of fear, anxiety, and worry. The outcomes from breast cancer have never been better. This is a fact, okay? And every day, every single person on this panel finds him or herself actively engaged in transmitting science, data, and the real truth to our patients, which translates into more optimism and more room for optimism than ever before. And you're going to hear all about that today. The second theme that you'll hear about today is a word called de-escalation, okay? This is a buzzword that all of you need to know, okay? As it's where we're all focused as it relates to breast cancer treatment on all fronts. You'll hear about it in surgery, you'll hear about it in chemotherapy, you'll hear about it in radiation. And this is really an interesting area because most people understand that research means more, better, faster, stronger, okay? Progress can also mean how we can pull back on some of these treatments in some patients while still delivering the excellent survival rates, sparing them a lot of the toxicities and side effects. In breast cancer, the age of precision medicine is right now. We are curing more and more people and want them as healthy and as strong as Stacy, if that is ever possible. When they graduate from our care. So listen for more today about de-escalation. It's the recurring theme. The only way really to fight misinformation is to provide the right evidence-based information, as our panelists here today are excited to do, bringing you some of the most up-to-the-minute understanding of important issues. And there are so many new issues that have come out, even in the last few weeks, and I hope we get to all of them. Our panelists are really thrilled to share their expertise and answer our most pressing questions. We hope that you will take this unique opportunity to learn all that you can and then share what you learn with your loved ones. You all are the lightning rods and the vessels of information that you can take out into the community and inspire others with your knowledge. And that's how we help so many more people. So with that, I will introduce my panelists, who I'm so excited about this year. If you're anything like me, just so you guys know, you cannot listen or think or operate on an empty stomach. So please enjoy your lunches while people are speaking. This is a working lunch. To get the ball rolling, I'm going to start by asking each of them an introductory question. We're going to go through the panel, and then we're going to open it up. Okay. First, we are going to go to Dr. Tiersten. Dr. Tiersten right here to my left is a highly experienced medical oncologist with expertise and training in both breast and GYN malignancies. She has conducted and led numerous clinical trials and published extensively in the areas of breast and ovarian cancer. Dr. Tiersten, let's start by asking you and having you address our poll question. So when most of you came in here, there was someone circulating with a question. We always like to start out with a question, okay? The question was, fact or fiction, true or false? In 2024, more women are receiving chemotherapy for breast cancer treatment than 10 years ago, okay? This has proven to be the ideal question because the answers were truly split right down the middle, okay? 49% of you said, yes, it's true, we're giving more chemo than ever before. And 51% of you said, no, that's not true, we're giving less. So I'm going to ask Dr. Tiersten to answer this question and why. And also, as part of the answer, can you tell us a little bit more about the study that Stacy was on, the COMPASS trial, and why it was so unique?
So Stacy had a type of breast cancer called HER2-positive breast cancer, and what's important to know about that type of breast cancer, which accounts for about 20% of all breast cancers, is that it overexpresses a protein called HER2 on the surface of the cell. These used to be considered more aggressive breast cancers since until we developed antibodies that specifically target this receptor. And Herceptin and Perjeta are the name of the antibodies, and they are some of the biggest advances in all of modern medicine. This is one of the really first targeted therapies that came along. So nowadays, it's actually considered better to have a HER2-positive breast cancer because you're a candidate to receive some of the most effective therapies we have. The standard of care currently is multiple chemotherapy drugs in addition to the antibodies. The antibodies need chemotherapy to work their best. And so standard of care is 2 chemotherapy drugs, which have a fair number of side effects. It's a tough regimen given with the antibodies prior to surgery. The idea behind Stacy's trial is that these antibodies are so effective that the hypothesis is maybe we can peel back the chemotherapy and get the same excellent results. So in Stacy's trial, rather than 2 pretty toxic chemotherapies, there's only 1 chemo. It's given for a much shorter duration, 12 as opposed to 18 weeks, and it's a much less toxic drug. And this is a trial that we've been accruing to, seeing great results like Stacy, who had a complete response. And we know that people who have a complete response have a great long-term outcome, and we achieve this with very little chemotherapy. And so this is a great example of a de-escalation trial.
How much less chemotherapy are we giving now than 10 years ago? What's the percentage?
For all types of breast cancer?
All types of breast cancer, across the board.
A fraction. I don't know exactly, but a fraction.
So
20
we
to
are
30.
giving less chemotherapy than ever before because of trials such as Stacy's. We're allowed to peel back chemotherapy and use the other more effective targeted agents instead. And this is a huge win for our patients. Thank you. Okay, our next panelist. Our next panelist, Dr. Anna Barbieri, is a double board-certified gynecologist and integrative medicine physician, and the founding physician of Electra Health. She is passionate about using her special expertise of combining medical and evidence-based holistic approaches to help women navigate menopause and other hormonal transitions. So, Dr. Barbieri, we're going to cut right to the chase here. Everyone wants to know about hormones. We all know that some patients with breast cancer can't take standard hormonal treatment because their cancers are fueled by hormones. What are the best and newest options for managing menopausal symptoms in both women with breast cancer and those without?
Sure, thank you so much, and thank you for having me here. So I'm sure many of you realize that menopause itself is kind of having a moment in the spotlight. I feel like everyone is talking about it. And when Oprah talks about it, everyone talks about it. So we're here. And it's really until recently that it wasn't a topic that was much discussed. Like a lot of women felt like they needed to hide their symptoms. They didn't want to talk about it. And that applies even more to women with breast cancer. When you're so focused on the treatment of that cancer, you may not even want to bring up your symptoms or not consider them significant. But things are changing, and I think it's with panels like this that we're kind of opening up the conversation. So hormones are complicated. For the non-breast cancer menopause experiencer, I don't want to say sufferer, but somebody who's experiencing menopause, the world of hormone therapy has changed a lot. It's a very, very complicated and a very individual subject. So many of us may remember a certain study from 20 years ago that said hormones cause breast cancer, that resulted in a massive change in the treatment of menopause symptoms. It is 20 years later, so we are doing things very, very differently. It would take me way more than 3 minutes to cover the decision to hormone or not to hormone for menopause, but it's something that I think all women should know about, and it's a very individual discussion. So I would say in the world of hormone therapy, we're in a very different place in terms of regimens, selecting the right person for that duration or even composition of those hormones. The good news is also that even for those who cannot use hormone therapy, which is going to be the vast majority of breast cancer patients, or people who simply don't choose to use them, we do have some new advances here. Just last year in May, there was a new medication approved. We call it FEZ. It stands for fezolinetant. It's hard to say. Also goes by the name of Veozah, and it is really kind of a remarkable example of how science can really advance our care of people. So it's really a molecule that acts on a specific part of the brain that goes a little bit crazy when estrogen drops, and a lot of hormone therapies for breast cancer entail a reduction in estrogen, and this particular agent can literally kind of act on that specific part of the brain, can be tremendously effective in treatments for hot flashes, night sweats, and potentially even sleep. So that's been a great tool to add to our repertoire.
Fantastic. So new things being developed all the time, and experts like Dr. Barbieri meet with patients all the time and work with them on an individualized basis to try and solve these really, really legitimate lifestyle and quality of life issues. Our next panelist is my partner. Dr. David Anderson is a board-certified and fellowship-trained breast surgical oncologist whose practice is dedicated to the treatment of benign and malignant breast disease. His clinical and research interests include the full spectrum of breast disease, as well as quality measures to improve the delivery of care. So, returning back to the de-escalation theme, David, how are we de-escalating and scaling back in surgery and the extent of surgery that we do in breast cancer? Tell us about what we're doing, and is there a possibility that there's going to come a day that for certain groups, they don't even need any surgery at all, and we get to take early retirement?
Hopefully not too early, but so I think this is a great topic. I do think there is a possibility that we can find low-risk groups who will not need surgery in the future. And I think that's kind of the underlying theme in terms of de-escalation with surgery, is that we're getting better in terms of picking out who is low risk, right? It's not one size fits all. We know that there's kind of more nuances to this. So we're getting better at picking out who's low risk. And in terms of surgery de-escalation, we routinely are used to sample lymph nodes up under the armpit for every woman with an invasive breast cancer, because that's the first place it could potentially spread. But we realized in low-risk women over 70, a lot of times we can omit that, and there's no difference in survival. There was a recent trial published at the end of this last year called the SOUND trial, and we actually just talked about this as a center, where they looked at women with early-stage breast cancers. There was no age restriction, so these are young women too, who, if they didn't have any evidence of lymph node involvement before surgery, they did not have any lymph node biopsy. And you're gonna start to see that, being put into practice nationally. So that's a big change in terms of surgery de-escalation. There's actually a few other trials where they've looked at DCIS, which is a non-invasive type of breast cancer, the earliest form, where they're looking at trials where they don't operate on the women at all. And they pick out the lower risk forms of DCIS, and they just actively monitor them with imaging. And that's already accrued and is over. We're anticipating the results hopefully soon, and I think we're optimistic about it. We are actually opening a trial called the RECAST trial here at Mount Sinai in Dubin, which is looking at the same thing, where women with low-risk DCIS can be actively monitored, and as long as everything looks good in the follow-up, they're going to avoid surgery. So I think some really important things going on out there. And kind of the vice versa of this, the other end of the spectrum is even some of our more aggressive cancer types, the HER2 positive breast cancers, the triple negative breast cancers. There's some very preliminary trials that are looking at these women getting neoadjuvant chemotherapy, so chemotherapy before surgery, and if they respond really, really well, potentially avoiding surgery at all. This is all, again, preliminary. It's not ready for prime time, but the question has been asked and people are investigating it.
Amazing, thank you. Okay, our next panelist, Dr. Louis DiPaolo. Dr. DiPaolo is a board-certified pulmonologist, but more importantly for us, he is the director of the health center at Hudson Yards, and he's the director of the concierge medicine service at Mount Sinai. So we're gonna just go for it, okay? Full body scans, okay? We are hearing about them everywhere, and every celebrity has been touting his or her, let's just be honest, mostly her, test of choice. What are the risks and what are the benefits, and which one should someone do?
Well, first of all, I want to thank you for inviting.
In 3 minutes or less.
No problem. Number one, I want to thank you for inviting me to be part of this panel. I couldn't figure out why I was invited to be here, except that I have 4 daughters and 4 granddaughters, so I figured that got me a place at the table. So, whole body MRIs, they're beautiful, magnificent pictures. In fact, we're beginning to teach medical students anatomies. We used to get a cadaver as a first-year medical student. We can now teach anatomy off of MRIs. So you get absolutely beautiful imaging from the brain down to your toes. We can define normal anatomy, and we can define abnormal anatomy. We can find benign disease, and yes, we can find cancer. So, as someone who's interested in art and photography, absolutely beautiful imaging. In terms of practicality, screening tests must be cheap, they must be specific, and they must be sensitive. The perfect screening test, pap smear. Dirt cheap, very sensitive, very specific. MRIs are not cheap, they're not specific, and they are overly sensitive. So that's the problem with it as a screening test. You can find a lot of benign diseases, and finding benign disease is okay if you can handle it. If someone tells you you have a thyroid nodule, which is probably benign, and you go into the cancer space, now you have anxiety associated with that diagnosis. So that's one of the downsides of getting MRI imaging. There's no radiation in the way that we think about traditionally with CAT scans, so that's really not a big issue. There is risk to your pocketbook, because the other thing we don't understand is what's the cadence. We know the cadence for breast cancer. We know the cadence for colon cancer. We know the cadence for other screening modalities that are past tried and true. What's the cadence for an MRI? I have no idea. It tells you I don't have cancer today. So do I do one in 1 year? Do I do it in 2 years? Don't know. So these are the downsides of MRIs. Where do you go? Without bashing vendors specifically, I always insist on getting the MRI images myself and reviewed by our radiologist. And my radiologist often calls me up and says, this is the trashiest scan I've ever seen. So the quality of the scan is important, because if you're going to bother to do it, at least do a good quality scan. It's interesting technology. Cost effectiveness, no one really wants to talk about cost effectiveness, but you have to do 6,000 scans to find one cancer you would not have found doing traditional screening. Mammograms, colonoscopies, pap smears, all the things that we normally do. 6,000 to find one that we would not have found. As a country, can we afford that? I don't think so. And I'll end at, I never discourage someone to get an MRI scan. Let's talk about it, understand what you're getting, understand what you're buying, then let's do it. And then you do find interesting stuff about your body, and so I think it's worth having that conversation, but it's not a recommendation, it's a conversation, and I'll stop there.
It's perfect, it's a conversation, and also important is it should never replace the tests that Dr. DiPaolo orders that we know work. We have patients coming in now saying things like, well, I just got a full body scan, I don't need a mammogram, I don't need a colonoscopy. That doesn't work. Those tests are tried and true, so it shouldn't displace those. And speaking of mammograms, Dr. Lori Margulies, a frequent flyer on our panel because what she does is so important, diagnosing breast cancer. She's the chief of breast imaging at the Dubin Breast Center, And she really established the center's innovative multimodality approach to breast imaging in our center. She's an expert in patient-focused care, advanced imaging techniques, and even the detection of cardiovascular disease on mammography, which we can talk more about. She also leads the mammogram VAN program, which provides really easy access to breast cancer screening all over New York City to places and people who may not be able to come to our center. Okay, again, in keeping with the recent news theme, 2 weeks ago, the United States Prevention Service Task Force guidelines, and they're the government agency that coordinates guidelines for screening and imaging and cancer detection. They changed their guidelines for beginning mammography, reverting back to original guidelines, confirming that we should start mammograms at age 40. Can you comment on the new guidelines and the need for additional imagings, sonograms, MRIs, which shockingly, the USPSTF says there's really insufficient evidence to support? I'm not leading the witness at all.
Well, the only thing I'd have to say beyond thank you all for listening to me is that I'm really not that crazy, but what I'm going to say is that crazy. So the United States Preventive Services Task Force is not an official government agency like the FDA or the CDC, but is incredibly powerful because it controls what insurance companies must pay for. So every year, Congress passes a law that says ignore the task force for breast imaging. It's a bizarre thing, but every year we wait for Congress to pass it, and every year, for many, many years, they've passed it. So what did they do just recently? They said, whoops, we made a mistake. You really should start screening at 40. And what we say? Well, of course. So if we look at who's been ordering mammograms, those people who have been in practice a while, like the people up here, have never stopped ordering at 40 because we knew the task force was wrong. But it's insidious because that's what our medical students and our residents are being taught. So our youngest doctors have been indoctrinated to start at 50. So we're back to 40. That's a big yay. But I gotta say, it's not a real full yay because they said every other year, which makes absolutely no medical sense. If you catch a breast cancer early by screening, research that Dr. Portnoy and others have done showed you're less likely to need chemotherapy, you're less likely to need a mastectomy, you're less likely to need the nodes under your arm removed. Finding it early is important. That can't be done every other year. And then it gets a little crazier, and I'm going to take 1 second to tell you about this. They don't want every year because we might get anxious. Okay. But the FDA, that is a federal government agency, will now require in September all mammograms to have a breast density paragraph that says the mammogram may miss some breast cancers and maybe you want something else. But the Preventive Task Force says, we're not so sure. Maybe the FDA is wrong. Doesn't make any sense. And to make matters worse, Medicare won't cover it, the supplemental screening, nor does the Cancer Services Program, which covers our indigent patients. So with that, I know my time is up, so I'll leave, but
We'll
I can
get
get on
back
my
to it.
soapbox for hours, so
No,
it's okay.
we can both go back and forth here. I want to just add one thing to this before we open it up. How many of you think the USPSTF, this committee that makes these guidelines, is composed of people like me, like Dr. Tiersten, like Dr. Anderson, like Dr. Margulies, who does all of the work related to breast cancer, who every day see the consequences of failing to screen? Isn't that what we would all think would be involved, the type of person, okay? What if I told you that the committee, and you can all Google this as I did and I researched, there's 16 people on the task force, not one of them, not one, is a breast cancer or breast specialist. There's 2 pediatricians, there's 1 psychologist, there are 2 OBGYNs, and most of the rest are primary care doctors, some of whom are actually involved in managed care, okay? So to follow up on, That I wouldn't. They have an MD after their name, so I don't know if you can be a lobbyist and be an MD. The point that I'm making is I think it's a huge misconception when these guidelines come out that it's doctors like us who are playing a role in making these recommendations when we're actually completely excluded because there's a perception that we would bias the results. Unlike a person who's works for an insurance company, has got very, very vested interest in cost saving. So I think that's very much important to know, and I invite you all to go to the USPSTF website and look up the committee and see who's on it. And you'd be like, oh my God, these people have nothing to do with breast cancer. Not a single one has ever treated a breast cancer patient. So that's important. So we're going to open it up now for questions. People can either raise their hand, their microphones, or if you don't want to, be public, you can also, I think there are cards on the table, you can write a question down and pass it to the front. But in the meanwhile, any questions from the audience? And you can think about things. There's one right here.
What role do you think genetic testing should play in the mandatory protocol, particularly as it relates to BRCA? Right now, it's sort of Wild West. It's not regularized or really popular.
Great question. So what role, and I'll give this to Dr. Anderson, the surgeon like me, what role does BRCA testing play in the general population and patients? And I'm just going to lay down one ground rule. This is the same ground rule every single year, which is please, 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 no questions of a personal nature. Our doctors can be here to talk to you after. And we're very wise to asking for a friend, okay? So no questions of a personal nature. So Dr. Anderson, genetics, tell us a little bit about that.
So genetic testing is very important with any breast cancer diagnosis or other cancer types, obviously. The BRCA 1 and 2 genes, as well as other high-risk genes, predisposes people to certain types of cancer. And there are national guidelines about who to test. There are also societal recommendations, meaning like, breast surgery societies and things of that nature that come out with recommendations where there are statements saying that every person with breast cancer should be or should have genetic testing. And so I think that is a lot of our practice. And these are important decisions because not only does it change what we may recommend surgically, but there are also medication reasons why we want to know BRCA status, like with Dr. Tiersten and her therapies. So that's very important. A bigger conversation is, population-wide testing and things of that nature, and that gets a little bit out of my realm of expertise dealing with breast cancer only. But I think obviously, family histories, things of that nature may prompt people to have it done, even if there isn't a cancer diagnosis personally. But I'm going to defer onto the general population testing because, again, that's not quite my expertise.
We do think that there are some groups who are at increased risk for breast cancer, gene carriers, like, for example, in the general population, the gene is less than 1%, but in the Ashkenazi Jewish population, it's 1 in 40, so 2%. So there is some push toward making sure Ashkenazi Jewish people, both men and women, should consider testing, especially in the setting of a family history. There's a question in the back, yes.
What do you all think about the use of AI in screening? I went for my most recent mammogram, and as I checked in to take care of my copay, I was asked if I wanted to spend an extra fee for the doctor to use AI to supplement the reading and analysis of my tests. What do you all think about that?
It's a great question to the point that we had it as one of our backup questions if the audience was too busy eating. Thank you. So I'm going to point to Dr. Margulies because she's actually leading the way in this field.
So I love AI. AI is almost a wellness tool for me because I know that if the AI says the mammogram, the screening mammogram is negative, there's a less than 1 in 2,000 chance that it will be wrong. What's great about Sinai is we do not charge for AI. There are private practices that are asking for approximately $50 a mammogram for that. So every single mammogram at Mount Sinai is looked at by artificial intelligence at zero cost to the patient for AI for mammo. So that being said, I'll just take 1 minute. So there are very subtle cancers that AI can find that the human eye doesn't. AI never gets tired. It never gets cranky. It never has to answer a phone call. It just does its thing. It takes a few minutes. And we won't read a mammogram without AI. If the computer is slow for a few minutes, we just wait. But it only takes a few minutes, and again, we don't charge for it, so we do it on every single mammogram in the Sinai Health System.
Other questions? One in the back, yes. Okay.
Given that survivor rates are so much better now than they were 10, 20 years ago, how much does the fact that you have access to more long-term survivors, like me, thank you, Dr. Port, how has that informed some of your research into other areas of those long-term survivors' health?
So let's do this 2 parts. Dr. Tiersten and also Dr. Barbieri, because one of the questions we really wanted to get to was the concept of sexual health as long-term well-being after, between surgery and the medications that you go on. That's one aspect of survivorship and quality of life. So Dr. Tiersten and then Dr. Barbieri, a few comments each.
Well, one very general comment is how we're curing more and more people is really what has led to this whole concept of de-escalation. As we see so many more long-term survivors, that's where we can really say maybe we don't need to give as much and get the same great results. As far as our long-term survivors, we do have a tremendous interest in other aspects of their life, such as sexual health. Fortunately, there's been a number of trials over the last number of years looking at ways, not just for sexual health, but ways to help with various lack of estrogen symptoms that we expose our patients to. Treatment for hot flashes, such as acupuncture, joint pain, other kinds of low-dose vaginal estrogen, for example, and I'll let Dr. Barbieri take it from there, is not considered a no-no in breast cancer survivors.
Yeah, I think this topic comes up a lot in my practice. One of the last patients I saw before this was someone who's actually been living with stage 4 breast cancer for years now. And this came up, but she was very busy checking off other worries on her list that had nothing to do with breast cancer, which I thought that was already a game-changing conversation. There does seem to come a time when a lot of women with breast cancer move from kind of the fear of dying from breast cancer to actually facing a whole new chapter of their long lives. So we do spend a lot of time helping them kind of navigate that part. Sexual health is one of the sort of areas of care that we provide. It becomes, sexual health becomes of interest to many women as we get older. And I kind of divide it into 2 different sort of categories. One is sort of genital, something called GSM. It stands for genital urinary syndrome of menopause. So it will virtually affect all of us once enough time has elapsed from menopause, and certainly breast cancer patients as well. There's a number of different strategies. There's ranging from lubricants to low-dose topical estrogens. We usually make that decision in collaboration with patients' oncologists, all the way to procedural things such as radiofrequency or fractional laser procedures that will reduce pain, increase lubrication. Low-dose estrogen can help prevent UTIs, which tend to become a more common thing later. And then there's also a group of sort of treatments or strategies for low libido, and that is something that affects also a lot of just women in general. And these treatments can range from really prescription non-hormonal treatments through certain strategies that are more behavioral.
Great. Any other questions? There's one over there, right here. Yes?
My question's for Dr. DiPaolo. You brought up an interesting point about kind of not being directly connected to breast oncology or breast cancer care. And as someone who's 2 years out from diagnosis and entering a new chapter, one thing I've thought about a lot is making sure, like kind of integrating everything together with all of my doctors and all of the kind of effects of the treatments on heart health and other parts of the body that I think doesn't get talked about a ton in terms of breast cancer. Like as you go on, how can you reduce some of the effects of the toxicity of your treatments or the ongoing endocrine that you're still on? What would you say, do you think there's an awareness among other practitioners for breast cancer survivors in terms of the implications on the rest of the body's, the metabolic health?
Absolutely. People who know me, my side gig is getting into longevity. And one of the things about sexual health is women live longer if they have more sex as long as they enjoy it. That's not true, by the way, not true for men. But for women, you'll live longer if, in fact, you enjoy it. So that's a perfect example of longevity. This is going to be my entryway into talking about lung cancer. I'm going to go on a rant because more women die of lung cancer than breast cancer. Let that sink in. More women die of lung cancer than breast cancer. So we're getting our mammograms. Are we screening all women? No. Unless you're a smoker and you fit into, again, a very tight, definition of a smoker, you will not be screened. 20% of lung cancers in women are not related to women who ever smoked. Smoking is 100 cigarettes a day. So there's an epidemic of death among women in lung cancer. We talked about the MRI scan. Guess what? The MRI stinks for the lung because an MRI takes molecules and vibrates them. Well, in the lung there's air. So you're never being screened. When you have an whole body MRI, your lungs are a black box. So again, if I can get on my pedestal here and say, please screen for lung cancer, even if you're a non-smoker. We don't have rules around that. In fact, if you go look up the guidelines, if you're a non-smoker, no guidelines. You're in a dead zone, which is unfortunate. So we need to know more about women. Women are different. We need to understand who we should be screening, what age we start to screen. So again, we have to have that conversation. When I have a smoking woman, I say, oh, your poor little breast. You're going to get a mammogram and you're going to get a CAT scan. Your radiation, you're getting radiated, your breasts are getting radiated twice. Well, guess what? We have the technology on CT scanning with algorithms to get all the information out of one scan. So at least get closer information. So we have a lot of work to do in that environment to really improve the overall health of women. So.
Before we take another question from the audience, there was one thing that had come up with a lot of people. I'm not going to throw anybody under the bus here, but there are at least 5 people in this audience who texted me or us about the breast cancer risk assessment tool that came out of the story that Olivia Munn told about her breast cancer. And it's a very, very, I think, important issue because if there's ever an opportunity to separate fact from fiction, this is it. People went into a deep dive tailspin with the story. The way the story was told was a person, any person with no perceived risk from breast cancer could walk into a doctor's office. They could perform some behind the curtain calculation and come out finding, oh my goodness, my risk of breast cancer is not the normal person's risk, 10 or 12%. It's 30%, it's 40%. How did that happen? Okay, and I think the most important thing to understand is a half-truth is misinformation. By telling part of the story, it's a lie. It just is. There's only 3 ways that women can have their risk of breast cancer increased. And most of these things we all know about ourselves. There's no magical risk that someone is going to tell you that you don't know about. One is hormonally, health-related factors. So if you had babies late in life, or if you haven't had any children at all, that bumps up your risk of breast cancer a little bit, okay? If you got your period before the age of 12, onset of menarche we call it, bumps up your risk a little well. So there are hormonal factors. Those hormonal factors affect a woman's risk by 1 or 2% maybe. That's it. Then there's what we call biopsy factors. If anyone's ever gone in to get a biopsy and the results are not normal, they're not cancer, but they're borderline. These are called atypical cells, LCIS. These are risk factors for breast cancer, okay? Most women know if they've gotten a breast biopsy and what those results show. Those results can bump up your risk by 5%, 10%. And then we get to the big kahuna, family history, okay? Family history is the big guns as it relates to risk. Those are the things that bump your risk up 10%, 20%, et cetera. And again, most people know what their family history is. So when you say, I walked into a doctor's office and you don't reveal your family history or the other risk factors, there is no way for a woman to be told she has a risk of getting breast cancer from 30 to 40% or higher without having a family history. So I don't know the details of the story, but without a family history of breast cancer, you can't get that risk level. And so to me, that was the big kind of community disservice by telling a half-truth or part of the story, which led to a huge misconception. And I think that this forum is just a great way of dispelling the hysteria that was actually generated by the story because of the misconception. Okay, next question.
We talked a lot about, the new therapies that are being tested, like for Stacey, for example. What do you guys think about all of the press that's been happening with the triple-negative vaccines that are being talked about?
Great question. So let's not only make it triple negative, but let's also talk about what's going on with de-escalation in triple negative vaccines and immunotherapy. And this is for Dr. Tiersten.
Triple-negative breast cancer is frequently treated in the preoperative setting with a combination of chemotherapy and immunotherapy. Immunotherapy are amazing advance, real game changer in triple-negative breast cancer. These are drugs that encourage a patient to unleash their own immune system to fight the cancer cells. And studies have shown that adding immunotherapy to chemotherapy for triple-negative breast cancer improves outcome tremendously. The current regimen, based on prior clinical trials, involves multi-agent chemotherapy with immunotherapy, followed by surgery, and then 9 additional treatments with immunotherapy. We know that patients who achieve a complete response to the therapy before surgery, meaning they have no residual cancer cells in the pathology specimen at the time of surgery, have a great outcome. And so we are participating in a trial of seeing if those patients that have a complete response cannot receive the 9 additional cycles of immunotherapy after surgery, because immunotherapy can have some serious side effects as well. So that's a great example of de-escalation in triple-negative breast cancer. Vaccines are part of immunotherapy, so to speak, and there's a lot of trials that are going on that are very, very interesting. None that have made their way into prime time yet, but I think it's a really interesting area of research.
Wonderful. Elizabeth.
You had talked about the increase in breast cancer in women who started having their period under the age of 12. And it seems that that has become a very big thing in our community, where girls are maturing at a much earlier age. What other aspects of, what are the environmental issues that most concern all of you at this point?
Anna, do you want to take that as it relates to women and environmental health, as it relates to reproductive health?
Sure. So we are seeing an earlier age at menarche for girls. That age used to be 13, 14, and now it has moved down. And I guess what we really have to think about is whether that increase in breast cancer that we see just has to do with the fact that that particular person is exposed to more hormones for a longer amount of time, or whether this is something that's related to that but separate from it. So I'll give you an example. One of the theories for why we're seeing this earlier age at menarche is because the average weight of girls is going up. And we're also living kind of in a world that's full of different chemicals, plastics, endocrine disruptors, and so on. So is it really just exposure to one's own hormones, or is it a combination between that and also our environment? And we're not quite sure, but what we are quite sure of is, for example, the diagnosis of obesity is going to raise one's risk of cancer, including breast cancer. We should absolutely pay attention to that for teenagers, for young women, for middle-aged women, for all of us. And metabolic health, I think Dr. DiPaolo mentioned it, is something that's really worthwhile to pay attention to.
Lou, do you want to jump in here? Anything about environmental stuff as it relates to general health that we know?
Well, so interesting, right? We're seeing they lowered for breast. We're seeing it for colon cancer. It was also lowered for colon cancer. So there's an epidemic, particularly in industrialized societies, of earlier detection of cancers. The fat issue is important because we do body compositions in our office. Because percent body fat, if it's high, I say, well, what does fat do? It stores hormones and stores toxins. So now all of a sudden you have a higher percentage of body fat that's holding on to hormones, exposing your breast longer, toxins, environmental toxins that we're seeing, food additives that are now being stored in fat. So I think there is a component to your body composition and the environment. Also, we talked about genetics. You asked about genetics before. There are somatic mutations, and then there are spontaneous mutations, and then the epigenetics is, you have a gene that by itself might not cause cancer, but now expose it to something that's environmentally toxic, and you turn that gene on, and you're off to the races, unlike BRCA. And that is a black hole for us in trying to understand the relationship between genes that we have that are pre-existing and the environmental things that we're being exposed to that are turning these genes on. And that might be the explanation for these earlier cancers.
Jamie. First, Jamie.
Hi.
Hi.
Question about radiation exposure and scans. I've been reading about QT as a technology to replace mammogram or to reduce the need for mammogram because of the high levels of radiation.
So I'll let Dr. Margulies take this. So this is such an important question because the perceived level of radiation with a mammogram, spoiler alert, is one of the biggest excuses that women use not to get them and is completely unfounded. Yeah.
So mammography has very low radiation. We're actually all exposed to radiation every single day. There's a measurement of radiation. So we call it, say, 3 of these millisievert things. So if our radiation here is 3, if we were to spend the year in New Mexico or Colorado, it would bump up to 4.5 or 5. So getting a mammogram is like being in New York City for about a month. Getting a bone density is like a couple hours, maybe. Getting things like PET CTs are a lot longer. That's about 5-7 years of living in New York City. But radiation is all around us. You can't avoid it. It's in the radon in our homes. It's in the air. When we go up in an airplane, it gets higher. There's actually never been a case of breast cancer shown to come from a mammogram. It's that they are incredibly low dose images. They are incredibly safe, and the early detection does save lives. There's no doubt that it makes breast cancer easier to treat and does save lives.
And
As a
Lori,
pulmonologist, I used to fight with my patients to get a CAT scan, and the metric was I would compare it to a mammogram and say it's as safe as a mammogram. So it's interesting that you were the standard for safety when I was trying to convince people to get a CAT scan to screen for lung cancer.
It's a screening for lung cancer is actually one of the low dose things, So if you screen for lung cancer, it's about 5-6 months of living in New York.
But I think you
And maybe
bring-
it saves your life, so.
I think you bring up a good point, Jamie, which is there are a lot of people out there touting new advanced imaging techniques with, and often in a predatory way that haven't been tested, are not ready for prime time, haven't been validated. And often to get people to do them, which by the way, they charge money for, right? So if you want to get, there are doctors out there that say, don't do a mammogram, do thermography. Dr. Margulies is my favorite. And by the way, it only costs $1,000 in my office. Lori, do you want to address some of these technologies that, and the one that I hadn't heard, quite frankly, the one you mentioned, Jamie, QT. I mean, what, yeah.
So when you go to these breast cancer meetings, there's always people walking around saying, you know, I'm starting a company. What do you think? Would you like to be a test site? And we try to run away from those people generally. There are obviously great ideas and great advances, and the breast cancer world is changing. Our mammogram machines are all going to be replaced by new mammogram machines as just technology advances to get even sharper, clearer images. But the basics still remain. Maybe someday there will be another test that's as good as mammography, but something that's reliable, that's inexpensive, that has moderate sensitivity, moderate specificity, isn't yet out there. And there are many people that are trying to get things that are other than mammograms because nobody likes the compression, right? So we're all working on it, but even breast ultrasound doesn't find all the breast cancers. Even breast MRI, which finds most of them, doesn't find all of them. So we're not there yet. Maybe someday we'll find something that's as good or better, but we're not there yet. And the thermography thing, they're just awful. They really won't save your life.
Tell us how you really feel, because I feel the same way. So, another question, right here.
What about radiation treatment? Do they still use it?
David, why don't you take this, radiation treatment?
The question was, is radiation still used, correct? Yeah. So it is still being used. However, just like with medical therapy, with surgical therapy for breast cancer, we're also de-escalating our radiation treatment. And so, again, the theme is we are finding, and we're better at finding who is low risk and who may have surgery but who may not need radiation afterwards. So there's lots of trials that have looked at that, and again, in women over 70 with low-risk breast cancers, oftentimes we can omit radiation completely if they've had, say, a lumpectomy and they've saved their breast. There are lots of trials looking at this in the mastectomy setting as well. So it is still standard, it's still very common, but again, we are also de-escalating radiation.
If you've been exposed to various radiation treatments, is that a lot?
Yeah, it's therapeutic radiation when it's done to treat a cancer, which is obviously more than what we were just talking about, just environmental exposures and things of that nature. But the sequelae or the side effects of these sorts of things tend to be, from a breast standpoint, really low. And the risks of long-term side effects of radiation are very low. And the benefit from a treatment standpoint, from a breast cancer perspective, is much higher.
Stage 0 breast cancer is also called DCIS. It's the earliest form of breast cancer. And I'm going to let Dr. Anderson take this because he talked about this a little bit as it related to, he didn't use that word directly, as it relates to some of the earliest cancers that we might be thinking about watching and waiting on.
Just as Dr. Port said, so DCIS is a stage 0 breast cancer. It's considered non-invasive, so it does not have the ability to spread outside of the breast. And it accounts for probably about 20%, 25% of all breast cancers that we see. Unfortunately, the survival is excellent. The prognosis is excellent. So you may come in with a diagnosis of breast cancer, but your survival is still very, very good. The mainstays of treatment for DCIS remain surgery and potentially radiation. But as I mentioned, there are a lot of trials going on that some have already accrued, some are beginning, where we're looking at just observing women with DCIS, because we know a good proportion of those patients, the cancer will never progress to a more invasive type. And so it's safe to monitor.
there's a lot about trials going on. Where is the best place for an average person to look on the internet, which is flooded with so much disinformation? Where would you find out potentially about?
As it relates to a diagnosis or
Correct.
relates to?
A diagnosis.
Amy, do you want to take this just because you?
The NCI has a government website, sorry.
The NCI.
The NCI has a government website that lists all trials, basically, and it has good search tools, and it's a great source, yeah.
I think it's a really great point because, you know, people have this idea, this conspiratorial idea that these guys are against these guys again. It's not true. We all want what's best for our patients. And actually, the internet has made it incredibly transparent about what different places are doing. And there is a fair amount of sending back and forth. You know, people from other institutions in New York know the work that Dr. Tiersten and our other oncologists are doing. And they'll say, they have this trial at Sinai that might be perfect for you, go there, and vice versa. So it's very transparent in terms of what's available for patients, especially after if they've failed multiple rounds of treatment. Would you agree with that, Amy?
Absolutely, yeah. And on the website, it'll say all the participating centers around the country and the closest one to you, and yeah.
And she gets a lot of inquiries that way of people from all over the country. People come to us now from all over the world, all over the country. Not only for clinical trials, but because of the reputation for excellence, of course, unbiased, that I think we've built. but these are all reasons why people come to us, and it's incredibly inspiring to see that the work that our oncologists are doing. Other questions?
Hi. The new mammography recommendations are great, but they wouldn't have helped me. I was 36 when I was diagnosed, and I was 6 months pregnant. You sort of touched on this before, but what's the reason for the increase in young women getting breast cancer and pregnancy-related breast cancer?
Sure. David, do you want to take this, and I'll jump in?
So I think it's a great question. It's a question that's really hard to answer. I think obviously if you're going to see more breast cancer in younger women, you know, you're naturally going to see that more in pregnancy. I think a lot has to do with screening and women's what they know in terms of when they need to start screening or who needs to be screened. I think that has a lot to do with it because oftentimes women, young women, you know, they have no idea that they should be going in for this, or that's not even on the radar, and they're thinking about a lot of other things like being pregnant and all those changes that are happening, and so things can kind of go by without being addressed properly. You know, in terms of younger diagnosis, I don't have an answer for you. I don't know if anybody does really at this point. It's a trend that we need to look at, but it's a big thing, and it's been out there a lot in the news.
And to get back to the question that was asked before, there are some explanations that perhaps, you know, the rising levels of overweight and obesity in this country. You know, people think of fat stores as these kind of like blobs of stuff we schlep around, but they're not passive. Fat stores are incredibly metabolically active. They produce things. They produce, everyone's heard now, pro-inflammatory agents. And maybe inflammation is a trigger for cancer. So it is possible that the sedentary lifestyle that all of our youth are experiencing now, and increased obesity, sedentary nature, all of those things are now manifesting themselves with increased risk of breast cancer. Fat stores produce inflammatory agents. They produce hormones. So that's why women who are overweight or obese are at higher risk for having a breast cancer recurrence, because they have more circulating hormones that are generated from fat stores. We know when we go through menopause, our ovaries stop producing hormones, but we're still women, right? We don't grow beards, our voice doesn't deepen, etc. Where are those hormones coming from? They're coming from adrenal glands, right? That's what keeps us being women. And they come from fat stores. So those are things to be aware of. And I think that it all feeds back to the question of whether or not the earlier onset of periods and, in fact, more exposure to hormones over a lifetime that's allowing for an earlier onset of breast cancer. one or two more questions. Patty.
Thank you. You were talking earlier about sexual health and what to do when you're into the next phase. Is there any research being done? There are so many products out there that are not prescription, particularly things like Reverie and Relazin. Other than trial and error of your own, how do you know whether this is something, for instance, that you guys would endorse? I mean, I've had great experience, but I don't know if I'm just guessing.
Dr. Barbieri, she touched on a couple of them. Let's just revisit, yeah.
Some of it is trial and error because some people just prefer certain lubricants compared to others. But, and I'll stick to lubricants here, but we do divide them into different categories for different uses. So in my office, for example, we have a bunch of them and we have people literally try them on their hand to see what the feel is like. But typically we divide them into water-based, oil-based, or silicone-based lubricants. Water-based are going to be kind of like, KY, for example. They really absorb very fast. They are not, they're just essentially moisturizers, so they don't last for too long. Then you have oil-based. They can stain clothing and sheets, so that's their downside. But oil-based lubricants like fractionated coconut oil, for example, it doesn't smell like coconut. It's clear. You can moisturize your skin with it. You can roast some carrots in it, and you can use it for your personal, intimate activities also. And then silicone is long-lasting. So there is some trial and error, but these are the main categories. When it comes to hyaluronic acid, there's actually been some studies done on vaginal hyaluronic acid, even comparing it to low-dose vaginal estrogen with pretty good outcomes. Reverie is just one of the brands of it. Relazin, for those, if you're interested, Relazin is made by that same company. It's a non-hormonal supplement for hot flashes and night sweats. The data on it is actually so-so. Some people do find it helpful. Some people don't find it effective at all. I would just caution everyone, especially in this group here, that if you are going to consider supplements, there's just so many of them. They are so heavily marketed and advertised. When we look at supplements with patients, especially when it comes to breast cancer, we take good care to divide them into hormonally active versus non-hormonally active supplements. You don't know that by reading somebody's Instagram post. You just really have to be very careful. Some of those supplements will have things in them that are phytoestrogens that can bind to receptors, and we need to be really very judicious in helping people kind of navigate that whole landscape.
And I would just add to that, because we never have this panel without bringing this up, that, supplements, just so you all know, are completely unregulated. They're a black box. The irony to me is people always say, I'm taking these supplements because I don't want the side effects of medications, and they're paranoid about the side effects for medications. If you are a person who is at all paranoid about what you put in your body, supplements should be the last thing on your list. They're made in all kinds of places like China and Romania, et cetera, where it's very unregulated, and they can slap a fancy label on them and make them look super wholesome and natural, and they aren't. So just be careful. I would like to say, unfortunately, our time has come to an end. We could talk all day. I mean, your questions are incredible, and you've been an incredible audience and participating and so forth, but we will do this again next year. First, thank you to my amazing panelists. Thank you. They're so busy, and thank you for taking your time to share your incredible knowledge. Each one of them could be a panel all unto him or herself. Thank you to all of you for joining us. We appreciate the support. So now you understand it, so that anyone can walk through the doors of the Dubin Breast Center and get the top tier care. I hope you realize that. We're committed to offering not only excellent care, but excellent care for all women. If you are so inclined, I don't think I could do a better job than our dear friend Stacy in promoting the cards. So if you're inclined, please contribute. And I also wanted to take this opportunity to share that we will be hosting our gala this year on December 9th at the Ziegfeld Ballroom. Please keep an eye out for the Save the Date card, and please consider coming and supporting. As you may know, we've transitioned to hosting this event every other year. So we took last year off, but we're extremely excited, and we really hope to see you there. It's going to be an incredible evening to benefit the center, and your support would be amazing. So with that, I would love to thank you for your attendance, for blowing this event out, and we wish you all a happy, healthy summer. Thank you.